Hello, hello. Hi, everyone. I'm Omar. I'm currently a second year medical student at the John Seeley School of Medicine with the University of Texas Medical Branch in Galveston. And today I'll be talking about our project. We looked at infectious disease risk among patients prescribed amoxapine and trifluoperazine, which are both a antidepressant and an antipsychotic medication, respectively. And so we were just talking about antimicrobial resistance, and I'm sure we all know it's a very big problem. It threatens global health. It leads to rising mortality, longer hospital stays, and escalating costs, all of which are very problematic for our healthcare system. But not only that, this issue is further compounded by the fact that the development of new antibiotics has been really reduced due to this issue of antimicrobial resistance. It takes a lot longer to develop new antibiotics, and it's a higher cost associated with it as well. So there's an urgent need for new alternative therapeutics, and one of them is drug repurposing, where you're taking drugs which have been FDA approved, they have a known side effect profile, a known safety, and you're repurposing them from their original purpose, like psychotic medications, to a new purpose. And that's what we're kind of looking at with this study. So right now I'm going to go over the previous literature a bit. So there's certain psychotropics that have antibacterial, antiviral, and immunomodulatory effects. And in fact, fluoxetine, which is one of the most commonly prescribed antidepressant and anxiety medications, it's been shown to have anti-inflammatory and possibly antiviral activity in multiple studies. Um, so this, our group with Dr. Chopra at the University of Texas Medical Branch, it inspired investigation, these results into investigating trifluoperazine, which is an antipsychotic medication, and amoxapine, which is an antidepressant, and looking at their survival benefit in infective murine models. And I'll go into it right here. Yeah, so they were able to find quite a few benefits within the murine model, specifically against Yersinia pestis, C. difficile, and Salmonella infections. And they did further cell cultures to really elucidate what the mechanism of action by which these medications were giving immune benefit. And what they saw was that, let me see if this works. There we go. So both of these medications had decrease in IL-22 and increase in IL-22 and IL-33, which led to more neutrophil recruitment. And then TFP, this was not done by our team, but another study found that TFP upregulates the PERK-2 alpha pathway, which leads to an antiviral stress response. And in a little bit, we'll kind of see how that kind of manifests in clinical populations. And at the same time, they lead to decrease in excessive inflammation, not in the short term, obviously, since we're seeing upregulation in IL-22 and 33, but over the long term, they've also been shown to kind of show a decrease in that inflammation. And so all of this really points to how their mechanism of action is more host modulated. Instead of targeting the pathogen directly, it's more so empowering the host through the upregulation of the immune system to better target that pathogen. So the objectives were our study to kind of just take this smaller scale data because it was in a murine population. And of course, the drugs weren't ready to be in a clinical trial yet. So we wanted to do a retrospective chart review and kind of apply this to see how these drugs manifest in terms of their anti-inflammatory properties and anti-infectious properties in a clinical setting. So one, we want to evaluate whether TFP and AXPN, those are the abbreviations for trifluoperazine and amoxapine, we want to see whether they are associated with altered risks of infectious or inflammatory illnesses. And two, we want to compare their outcomes both to a general control group and to those prescribed fluoxetine. And so here are our methods. So we took our data from Trinetics, which is a federated national data work. If I'm not sure how many of y'all know about this, but it's a very large data network and it's very helpful for running large scale analyses in a relatively fast manner. It has over 75 million de-identified EHR charts within it, and it aggregates this data from across the nation. Um, our study type was a retrospective cohort study. We looked at adults greater than 18 years of age who had been prescribed either TFP or AXPN. And our comparisons, we had four main comparisons. We had TFP versus a general control, AXPN versus general control, and then TFP and AXPN versus those prescribed fluoxetine as well. Because as I mentioned earlier, fluoxetine has been shown in multiple sources of literature to have antiviral and anti-inflammatory properties. Um, Oh, and just for reference, our general control group, that was basically any patient who had a general wellness exam coded with the Z22 code in Trinetics. And exclusions, patients with cancer, severe immunosuppression, or major psychiatric disorders were not included. We definitely acknowledge that these populations are important to study. The main reason we didn't include these populations in our study was because of the possible confounding in terms of inflammatory effects or social and demographic factors, but we definitely think future iterations of this study should find ways to include these populations as well. And further going into the methods, we did propensity score matching. So we did age and sex matching. We also did matching based on the Charleston Comorbidity Index to really limit confounders as much as possible. And the Charleston Comorbidity Index kind of takes into account a lot of different comorbidities, including vascular disease, heart disease, liver disease. And we looked at a total of 16 different outcomes, which I'll be going through in a little bit. There were infectious, inflammatory, and clinical outcomes, including COVID, pneumonia, leukocytosis, and mortality. And for statistical analyses, we ran risk ratios on each of these, got our confidence intervals, p-values, and we performed Kaplan-Meier statistical analysis for any outcome that was statistically significant. And this is just kind of a reiteration of what I've been mentioning earlier. But basically, we had our Trinetics network. We split it up into our different cohorts, did that propensity score matching, looked at our outcomes, and from this, we were able to get our risk ratios and survival curves. So for trifluoperazine, which was the antipsychotic medication, its brand name is Stelazine, by the way. We saw significantly reduced risk when it came to COVID-19, bronchitis and lower respiratory tract infections, and ENT and dental infections. And at the same time, we saw an increased risk for leukocytosis, which was defined as an elevated white blood cell count greater than 12,000. So the findings were consistent both when doing a general comparison to the control group and to fluoxetine. On the other hand, amoxapine had fewer consistent associations compared to the larger associations that we saw with TFP, but we still saw some associations. We saw a protective effect against C. difficile infections, and we saw interestingly reduced leukocytosis, kind of pointing to that anti-inflammatory property of amoxapine that we were looking at in the literature. And other infection risks, however, remain comparable to the controls. And then this is kind of just a general table showing the findings and kind of the end values in each of the groups. So just to reiterate, TFP versus the control group in the elderly population showed decreases in COVID, bronchitis, lower respiratory tract infections, and ENT dental infections, but an increase in leukocytosis. Um, when we looked at the younger population, we didn't see as many significant outcomes, but we did see a decrease in ENT dental infections, and that increase in leukocytosis was sustained. However, another thing to note is that the N was a little bit smaller in this group. Amoxapine versus control mainly showed that increase in leukocytosis, and but when we compared it to fluoxetine, we saw a decrease in leukocytosis and a decrease in C. difficile infections. In the Kaplan-Meier survival findings, the curves mostly kind of just like they amplified the results. So they showed higher event-free survival for COVID, ENT dental infections, and bronchitis, lower respiratory tract infections in the TFP cohort. Among the AXPN cohort, they showed survival advantage for C. difficile and lower leukocytosis in older adults. So they were mostly just kind of further validating the results we had gotten from the risk ratios. So what does this all kind of mean? So TFP's associations, they align with its known immunomodulatory and antiviral properties that were kind of like mentioned in the literature, particularly relevant when it came to COVID-19. It showed significantly antiviral properties in that case. AXPN showed potential immune benefit as well, especially with the decrease in white blood cell count it showed compared to the general control group. But both drugs appear to modulate inflammation independent of the direct antimicrobial effects. So they both have that host-mediated immune mechanism. But of course, another important thing to note is that our outcomes in this study were more, they weren't as specific. So we were looking at ENT dental infections and bronchitis, lower respiratory tract infections, but we weren't able to isolate the specific pathogens due to time constraints. And definitely future iterations of this kind of should kind of look into further isolating the specific pathogens that are leading to like that reduction in bronchitis, lower respiratory tract infections, or ENT dental infections. And some limitations of this study is that this is a retrospective study, so you can't really confer any causality from these results. There's also diagnostic and reporting variability across institutions. So while Trinetics aggregates coding, a lot of us working in healthcare may know that coding is not always consistent among institutions. And so it tries its best, but there can be variability due to that. Medication adherence and dose was also not controlled for. Trinetics unfortunately doesn't allow you to specifically see the dosage of the medications that patients are being prescribed, so you can't really get a dose response curve. And residual confounding could have been present as well, despite the adjustment for the Charlson Comorbidity Index and age stratification. So overall conclusions from the study is that TFP demonstrated pretty consistent protective associations across multiple infectious and inflammatory markers, and AXPN showed more targeted benefits, especially in elderly patients. The findings definitely support further clinical and mechanistic studies into psychotropic drug repurposing for infection management. And just some future directions. Definitely one thing is to look more into the specific pathogens, which our group plans to do in the coming months. Specifically, isolate the pathogens that are resulting in those ENT dental infections and decreased bronchitis, lower respiratory tract infections. And more studies should be done on the mechanistic mechanism by which these medications are performing to look at those cytokine and immune cell pathways, so to see if there are any other avenues that these medications are working through. And then eventually, if enough data is received, prospective trials could be evaluated to look at TFP and AXPN in infectious and post-operative settings. And particularly for post-operative patients, we could see the effectiveness of infectious prophylaxis with these types of medications. Yeah, that is everything I have for you guys. I want to thank my wonderful team. I want to thank you guys for giving me the platform to talk about this work. And